What's going on, everybody? Welcome back to another week of AJ's Views on Orthopedic Surgical Considerations. This week we discussed a couple different procedures about the shoulder. Um, we know that the shoulder is a very complex joint. It has a lot going on with it. And with this week's topics or things that we discussed, um, the surgery that stuck out, or procedure that stuck out to me the most was the slap tear repair. So we're going to talk. This episode is specifically going to talk about a slap tear and what a slap tear is, and talk a little bit about, a little bit about rehab, a little bit about what things may work for rehab, and provides a little bit of context about some other things as well. So let's get into it. So, what does SLAP stand for? Okay, SLAP stands for superior labrum anterior to posterior. So this means that there is a labral tear from anteriorly to posteriorly. So that means that it's a significant issue to the labrum in the shoulder, right? So we know that the shoulder is a ball and socket joint, where we're gonna say my hand here is our glenoid, right, and then my fist here is the ball, and around this glenoid lies a ring of cartilage and tissue called the labrum. So typically, the primary mechanism of injury for a slap tear is going to be a fusion mechanism. That means falling on an outstretched arm, or going to be a shoulder dislocation, or some other chronic shoulder instability that is caused by repetitive trauma. So what are some symptoms that is indicative of a slap tear, right? So this can include a feeling of locking, popping, clicking, or catching sensations, a feeling of apprehension. So as they kind of go into external rotation, they feel like their shoulder is going to give out, or even the shoulder is going to end up dislocating. And then you'll also see decreased strength and range of motion compared bilaterally. So examination. This week for me, as I was reading the literature, the rehab group was great. Talking about the surgeries was great, but I always wanted to know, because I'm a big shoulder guy, I really love the shoulder, is what diagnostic battery helps us include or exclude a potential labral tear, right? And from our differential diagnosis, right? So some of the tests that were talked about, right? They talked about there's no one singular test that is able to determine one of the articles you read this week said there's not one singular test that can determine if someone has a slap tear or not. But a combination of these tests can help either rule in or rule out a potential labral pathology. So obviously we know O'Brien's test is one of the tests that were included. The second is Speed's test, which is used a little bit, has some good sensitivity, specificity, and especially from the research, but I don't use it too much in my clinical practice. The third one is the Jurgensen's test, or biceps provocation test, right? We're trying to get that long head of the biceps tendon to kind of cause some provocation or some symptoms. And the last one, which is one I like to use a lot, is the shear/crank test, right? This is where you are putting the shoulder in external rotation, and then you are providing a load from posteriorly anteriorly as you're forcing this arm into external rotation. Usually as you're kind of cranking on the shoulder a little bit, this will end up and you're moving the shoulder around, you'll get that, you'll sometimes feel the clucking and the popping or the catching, but also you'll feel that shoulder kind of like give a little bit of apprehension, right? As they're going back into that motion, you just feel I'm feeling something kind of going on. But we know the MRI is really the gold standard to letting us know if there's a true labral slap tear in a specific athlete. So let's talk about treatment, right? That's another thing that was discussed a lot in the articles this week, was treatment of a slap tear. Can it be done non-surgically? Can it be done surgically? What are the options if it's done non-surgically? What are the options if it's done surgically? So non-surgical, typically a lot of the research that we read this week said 3 to 6 months is usual of rehab with a athletic trainer or physical therapist working on improving strength, improving stability, improving anterior and posterior capsule stability, improving range of motion. All those things are important, right? But what happens if it doesn't work, right? What happens if this conservative treatment doesn't work, and we're still having instability. We're still having sensations of popping, kicking, and popping, clicking, or catching. Now we're going to discuss surgery. So obviously, we talked about this week two surgical options, which is going to be for the slap tear, would be an open procedure or arthroscopy. Arthroscopy, right? So arthroscopy is a standard procedure nowadays for a labral repair, but an open procedure may be considered if poor visualization of the labrum is found, right? If, let's say, the surgeon get in there with the arthroscope and they have their other tool as well, and they're looking in, trying to see what's going on, and they don't have good visualization of that labrum, they may choose to do an open procedure to make sure they have adequate visualization of the tear so that they can repair it properly. So how does that surgery work? So really simplistic here, not going to spend too much time on steps here, because the literature this week did a great job showing us pictures and showing us really in great detail how the surgery is done. So usually there are two incisions made as to serve as portals for the arthroscope and the respective tools, and usually that's done one in the anterior shoulder and another one a little bit on the posterior shoulder. Once the surgeons get in, they're going to observe the glenoid and the glenoid fossa, and then they also are going to identify the torn labrum, because that's what we want to see. We want to make sure that the torn labrum is visualized. As the surgeon gets in and the repair is decided, the surgeon will use a rasp and a shaver to prepare the torn section of the labrum. Then the surgeon will then drill a small hole in the glenoid to anchor the suture that is going to basically now serve as a repair for that newly repaired labrum. The labrum is then stitched and anchored to the suture, and then that suture is passed through that hole and anchored down as well against the glenoid. And the goal here is to make sure that it is laying flat against the glenoid. So let's talk about some potential complications. So first, we're always going to do any surgery, we're going to discuss infection, right? That's a big thing. But two is, what happens if I still have reoccurring instability, right? What happens if my shoulder is still unstable and the surgery did not work? The third one is maybe increased stiffness. Maybe you have the surgery, but you don't regain full range of motion. Your shoulder's always stiff. You feel like it's just not going good. So these are some things you definitely have to consider. But as the research showed us this week, right, we know that there's a very high return to sport rate for individuals who end up having a slap tear surgery. So this is something that, as long as the rehab is good, and I think in one of the articles that we discussed, one of the reasons why that a lot of us talked about was one of the reasons why maybe surgery failed, and is because of the rehab, right? Rehab is a key proponent to discussing a slap tear or any shoulder surgery itself. It's important to note that the rehab is important, right? We have to start at the basics first. So obviously post-surgery, they'll be immobilized in a brace. Usually in the research we saw this week in also of our shoulder surgeries, it's about a 2 to 6 week window of immobilization. And then from there, we're starting those exercises, right? We're starting those range of motion exercises, maybe some cane range of motion, some isometrics, moving on, doing some pendulums, then moving on to doing some more internal, external rotation at zero, doing some scapular work, getting things firing right on the right pattern, doing some things that are going to help prepare the shoulder for greater load. And as the rehab progresses, right, we're still working on increasing strength. We're working on increasing range of motion. We're working on increasing scapular stability, right? So maybe including exercise that involve perturbations, right? Including exercise that involve a lot of eccentrics, right? And that includes maybe some eccentric throwing, maybe and one of my favorite eccentric exercises for the shoulder is a side lying eccentric external rotation, where the patient is side lying. And they're going into external rotation, and then you as a clinician are forcing them or pushing them back into internal rotation, right? So that's one of my favorite exercises to do, along with some of a manual series that I learned while I was in grad school, actually in undergrad. That's really, really great in helping prepare the shoulder for high loads after like toward the end of the return to play process, especially for contact athletes such as football players. So again, right, this week we talked about a lot about the shoulder, but I really want to focus on the slap tear, and I think the slap tear is a really important piece. Surgery that is discussed a lot, especially in high contact sports like football, and that's where a lot of my background is in. So again, thank you guys for tuning in this week, and I hope you guys have a blessed one.